Hey folks, my name is Dr. Amy Pearlman. I'm a board-certified urologist with expertise in sexual health, hormonal health, and genitourinary health. And I have Dr. Kevin Zorn here with me today at the American Urological Association meeting in wonderful Las Vegas. Oh, we didn't say that at the same time. You say 1, 2, 3, Las Vegas.
And warm too, coming from Canada. So you guys, you're in Miami, so you're quite lucky, but.
So, Dr. Zorn, why don't you give yourself a brief introduction to our audience?
Sure. Dr. Kevin Zorn, urologist who practices in Montreal, Canada, formerly at the University of Chicago and the University of Montreal, academics for up until like 2 years ago, so almost 20 years in practice. Now subspecializing in prostate pathologies, mainly BPH. So opening up BPH Canada, a center to really offer men across Canada all of the different technologies in an expedited fashion and in a personalized fashion, which has become, what we want as a patient. And I guess my dream as being a doctor was to deliver the care, be a teacher, and deliver all the other elements beyond the surgery. And that's what we're been able to develop.
Now, we oftentimes think that you have to be in academics to be involved in all the innovative research. And now you're very much in a private practice. Why don't you give your take on research in academics versus private practice?
Sure. You go through your career and you finish up your residency and you're in your bubble. The people that you train you is sort of the dogma of the way it is. There's Campbell's, the Bible, or whatever choice of religious book that you have. That's you follow the commandments. That's how it was done. And you get your pager and here's your call schedule and off you go. And, hopefully you have mentors that have set you up in your fellowship of how to become dedicated, kind of like going to the gym. You got to do your research, collect the data, be at these kind of meetings, and then that sort of drives the momentum. And I did that, and I built it up through El Halali, through some of the research of BPH and Dr. Shalab in Chicago, and that kept me going. And in Canada, there's not as much maybe opportunity and funding as we see some parts of the U.S. And so that kept me going. And to then break off and think, well, what led me? And then think along life is like Plinko. You meet people like yourself, Dr. Meehan, Dr. Neil Shore, another one who I came into contact with, and he's in BPH. Yeah, he was in a ZenFlow study, and we chatted, and it was amazing how this year was the most prolific abstract submission and acceptance. We have 13 abstracts we submitted for just sort of for Aquablation.
Yeah,
we did 3 for Huptaloom. I submitted 1 on Fallowfill. So 16 or 17 abstracts.
Yeah.
I have a large research team of residents and students from both McGill University of Montreal and McGill, who come on their own after-hour time to be with me to do research. So we have what's called the Zorn Lab. Once a month we meet, and ICARUS, which is this international collaborative group. And I think that's the fun part now. Technology and being on social media, we gel with other people. We open up our doors. So Dr. Helfand in Chicago, Dr. Glazer, Dr. Marhamadi, Dr. Tiago Rodriguez from Portugal. We put together the ICARUS, International Collaborative Research Group. So no longer are the confines at the university level have opened up. You have external IRBs, things move quicker. And I'm doing more research now, like kind of Neil Shore said to me, you can practice, you tell your practice versus now being on call and taking whatever comes in that you also have to take care of that gets now blocked out. You can focus your career on what you love to do and I think deliver the educational portions and all the little minutia. That's what makes good to great. It's delivering those other elements of personalized care, not feeling rushed, and whatever's new that's out there, you can bring in and also test it much earlier than I would anywhere else.
Yeah. And even outside of the research that you're presenting at the AUA on different technologies, in your BPH practice, you offer the gamut of technologies. And you've done studies on like every single technology in this space. I used to do a lot of voiding dysfunction when I was at the University of Iowa. I don't do it in my current practice because I don't offer all the different therapies. And I just feel like I love getting into the weeds and offering every single thing within a disease process. But that's really challenging to do. And I don't know of too many other people other than you that do that. How are you able to offer all these different technologies as, I don't know in any other space there are as many technologies coming out as quickly as BPH?
Well, number one, you put your finger right on the button. Yeah. BPH is exploding because aging population, a lot of technology out there, a lot of men with BPH right? 100 years ago, we only made it to 50.
Right.
After that, we're in a box. We're not supposed to be here. So that's exploded the length of life and our technologies. We're learning at this AUA the importance of ejaculation, which was once tucked under the rug. There's a 1 in 5 chance 100 years ago when I started doing, the human race getting TURP or open simple prostatectomy. There's a 1 in 5 chance you're not going to make it. Survival was their biggest.
Like living through the
mortality. To now we're finessing between, do you want a catheter? Would you like to, have ejaculation? How's this going to impact my sexual function? Can I go back to work? Do I want a catheter? So with that, I think is that whole individualization. And I love it. I mean, my mentors, be it on planet or up in the sky, like Dr. Al-Ali, are still major components of, my thought process in the healthcare of my patients. And they're there for the research and what have you. And I'm passionate about what I like to do. And I just think at some point, if someone comes to see me, there's no coercion that I'm going to choose one procedure over another because that's all I can offer. So I think the key here is that, if you go to a vacuum shop, I don't know if that's an example, but you know what I mean? Like,
do you have vacuum shops anymore?
No, but no. And near me, there is. There's one that if you have you need that small part on a Dyson or, or those home suctions, you need the small part. And you want to go to a store like that has it all. Yeah. And I just feel what was taught to me, again, you bum through life. And before I moved into this practice, I spoke to other specialists and who better understands kind of private practice than plastic surgery. So Dr. J.P. Brutus, not a urologist, a hand specialist. So if you want to go get your lips done or your breast, he won't see you. He just does hand. Yeah. SME, subject matter expert. That's what his advice was. And I just said, look, to do that, you have to test everything out and offer it.
So at this meeting, you're going to be in a plenary actually coming up pretty soon here. And you're talking about the role of ejaculatory preservation in BPH therapies. What is your message during this plenary session?
Well, it's important. It's, it should become standard of care. You do a history, you do a physical. We should be using standardized questionnaires like IPSS. Like in 2018, first time we told everyone, if you're doing BPH surgeries, measure the prostate volume with an MRI and ultrasound. 2018, 7 years ago. We know people before surgery was just kind of, well, this is not a good tool. So validated questionnaires, and we should be asking, do you ejaculate? Is this important to you?
Yes.
Is this, what we've seen from many of the abstracts here and even previously published, that it's age independent. It's just not that you're 70 plus that,
Oh yeah, my Miami men. That's a big deal.
So the term is men are living longer, they're healthier, they're wealthier, they're more active physically and sexually. And I think that's, unfortunately, we have to break down the myth that, they're old, they're going to be in a nursing home, they're not doing anything. They are. And I think that's an important feature that has to be discussed. It's part of informed consent. And I just really expect that to be something that everyone walking in here understands and should be bringing into the conversation. So when they do their, patient shared decision of what treatments are out there, that has to be on the map. The next is, we have technologies, and it's been 2015 UroLift. We have Resume, we have iTind, we have Optilume, BPH, and we have a few more coming.
So stay tuned for next AUA.
Right. So that's a whole other discussion. But the key thing is that we have these technologies that have 3-5 year data that show, at least the short term, midterm, they can do as good of an IPSS reduction, Qmax and PVR improvements that maintain sexual function, and all less than 10%. And I guess in the spotlight, everyone was asking me, is this just an Aquablation talk? Well, no, but it's the Da Vinci robot that allows us to see better, like magnified vision. Now we have a magnified ultrasound real-time view that we never had before, right? You do a TURP, you engage the tissue, how deep you're going, we'll find out.
Yeah.
Right. And then, I got to capsule. Don't go further. Now we actually see a distance where, the anatomy is. And so with that, we've come to realize that the bladder neck is not the answer, right? We were taught the bladder neck, preserve the bladder neck. With Aquablation, we blow it open. It's the tissues behind the verumontanum. It's about 10 millimeters behind the verumontanum, 7.5 millimeters on each side. So it forms a triangle, AKA the butterfly cut. And if you can do that with Aquablation, it was an 80 to 85% in the Water 1, Water 2 trials that we can preserve ejaculation. So it's something, the magic sauce is there. And then the question is, Can you transport this to TERP with whole up laser? Yeah. And others have published on that. So if you are part of the 90% of countries that don't have aquablation, or it's not available yet, you can modify your technique to deliver that. It's not hard. So it's simple, one by one, let's say, around the verumontanum. And then to me, the next magic that I'm hopefully going to present is, can we do better? Where's my insight? So one is, you cannot protect what you cannot see. So we all can identify the verumontanum, right? You're in a cysto, what's that? Vero, right? And there's a magic hole there. What's on the other side? Where does the ducts go? Where do they project to? Are we going wider early that we're not in that butterfly zone? And that's why we're getting into this retrograde or anejaculation for those patients. So if we don't know where the ducts are, so stay tuned. I'm going to present on the RVU, the retrograde. So if you inject saline retrograde.
Don't give away all your secrets too soon.
Well, are we not live? This is something that's, you're going to watch the reruns, but there's that and there's micro ultrasound. So we can pick up details. And so I think that will help us do better. Kind of like, this is just an evolution. We're on the iPhone 5. There's next generations. That my forecast is we're going to be talking in 10 years from now. How do I get rid of dysuria? How do I open up someone's prostate? And rather than having a denuded chamber, how can I line that with urothelium so that there's no dysuria, there's no hematuria, right? If you took up that much, right? It was the innocent bystander. We didn't even think about it. Is the urethra. We have to damage the urethra for 5, 6, 8 centimeters circumferentially. And if you take that surface area and you say, hey, you know what, Amy, I'm going to cut that skin off your leg.
Yeah.
You're going to heal on your own. Yeah, and you're 75, you're diabetic. And you get to urinate on that a couple of times a day. It's mind-boggling. But men who are visual, they look down, they don't have a catheter, they should be okay. And they don't see what we see or what we know is inside. So that's the next needs a tackle. I think that's maybe, AUA 2035, we'll be sitting here having that discussion. So that's it. I think those are the messages. We got stuff.
Yeah.
Have a talk with your patient. And it's part of that. Let's sit down and really dig down who you are, what's important to you. And how do you do that in a safe, secure environment? Because not everyone always opens up about their sexuality. Yeah. I think that's the part of being an approachable, easygoing, and I think sometimes the validated questionnaires are good. And that's the last part is the MSHEQ developed, I want to say in 2004. So it's about 20 years old, and it's 4 questions. It's self-referred. It really doesn't look at volume. And I really think that even though we preserve ejaculation, the mechanism, the movement, you have to really sit down and tell the patient, it's not going to be the same amount of sperm. It's not going to be the same pH. It's not going to liquefy as well because we were taking out the prostatic components. And it may sound like, who cares? But I think it's just important to have that conversation.
Yeah, it's interesting. I was recently talking with a urologist, and he has a company, Popstar Labs, and they have like a volume and taste supplement, which I know sounds a little bit crazy. I don't know if you've heard of it before. Hearing about this supplement, you kind of, as a urologist, are like, does it really work? That sounds strange. Who would actually want it? And when I was asking him, who are the types of men that benefit from taking this type of supplement? Actually, one of the groups of men he mentioned were people after prostate, procedures for BPH, where you can actually impact their ejaculatory volume afterwards based on his experience. So I'm kind of excited about that. I don't know. Stay tuned. Maybe we'll publish something on it. But
supplement that's going to...
It's a supplement for ejaculatory volume. Yeah.
All right.
Yeah, and the thing is, I literally told this urologist, I said, I don't really have the patient population that is going to come in to see me to say, I want to have more volume. Literally the very next day, I sat down with a patient and I said, how can I help you have better sex? And his response was, I want to have more volume in my ejaculate. And I was like, okay, maybe I might have something for you.
Would 3 days of abstinence help or?
Yes, that definitely helps. And hydration is definitely very
Sure.
But
it's like TRP, the more hydrated, the more you get. So I was wondering if some guys, delivering 5 times a day, the supply demand chain may not be there despite whatever supplement you have. So I think, having that conversation too, or sometimes, some patients have come to see me and they have trouble getting erections. I'm like, on the first or the second, like on the third, like I just got into a new relationship. I'm like, and you're 50. I'm like, you're my hero. Number 2, the other aspect of having realistic expectations, I think is coming to, again, having the conversation, understanding, and I learned at McGill, which is take a good history and a good physical, a lot could be done. And it's just amazing if you take the time and you're a good history taker. So,
as urologists, oftentimes we go into this field because we like the jokes. We're going to have to come up with a new joke, because a common sort of joke or funny thing that we'll say to patients when we talk about BPH procedures, oh, it's less mess. I'll put you on some medication. You may not have antegrade ejaculation, but it's less messy. I've stopped saying that because actually some people find that offensive. It's actually not funny to say that this important quality of life concern is not actually important.
And I've been guilty of that too. And usually it's the wife that leans over, is like, yeah, it's like less laundry. I'm so glad. And, we don't ask the question is that, there was one of the slides I'm going to be presenting is Lee et al. From 2004, in which they just had sort of a visual cue of a man ejaculating onto his tummy, let's say, is the force of the ejaculation and the volume and the angle related to the satisfaction. So like, I can't get no satisfaction, like the whole idea, but that I think part of, and for patients who take Rapaflow, like a very selective alpha blocker that we give to BPH patients. And I think I've seen urologists give it to younger men, and it creates an issue of trust, because I took a medications and they stopped it, or they took it and they think I have a complication. Or 3, the way it was described to me was that when you take this, it's like you're trying to blow out a candle on your birthday cake and you have COPD. It is just the most ungratifying, unsatisfying ejaculatory movement. And it just comes to that point where we don't even get into that. What's the intensity of your orgasm? And then that's a whole other, there's a lot of other elements that we don't even understand. Memories or environmental cues or the mood. I think all those play a big factor. And we're only in discovery mode, because for many, 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 many years, we don't talk about
AUA 2040.
Yeah. And that's one of my things, is that I think one of the things that we just only recently debunked was for men who are, the orgasm, so forth, that if you do it too often, you have medical issues, that you can become blind or so forth. And the last thing that was the real winner to follow that is that it could be helpful, beneficial, that you can lower your risk of prostate cancer. So if anything, I think having that conversation is quite cool. So I think we love what we do in urology, and it shows what we do with our patients.
I love it. Well, Dr. Zorn, thank you so much for joining me today.
Yeah, thank you very much.
Until next time.
Until next time.
Thanks, folks.
Bye.